our brains are sort of freewheeling during REM sleep in a way that we don't allow it to when we're awake.
Mm-hmm.
So there are thoughts and images and connections that we can make during REM sleep that our logical brains, won't let us do.
Mm-hmm.
And so what comes up during that state, if you can remember it during the daytime, should be analyzed. What is happening that I'm not paying attention to when I'm awake?
Mm-hmm.
And
Mm-hmm.
what is important about that? I know
Mm-hmm.
for me, I've had dreams of tornadoes or spiders.
Mm-hmm.
And when I wake up and think about them, I can identify something in my life that is out of control
Mm-hmm.
with a tornado or dangerous in ways that my conscious mind just was unable to even recognize.
Welcome to the Better Brain Podcast, where we talk about everything brain health for anyone who has a brain or knows somebody who does and wants to make it better.
Our guest today is Dr. Gina Poe. She's a distinguished neuroscientist here at UCLA. She studies sleep, specifically the role of memory consolidation in sleep, as well as its impact on brain and mental health. Dr. Poe's research has significantly advanced our understanding of how REM sleep contributes to memory consolidation and restructuring, and its relation to brain and mental health.
We start at the top, talking about the architecture of sleep, going through some of the basics, demystifying and raising a lot of curiosity about each stage of sleep. A lot to learn about sleep still from a scientific perspective, but I hope this makes everybody really curious about their sleep, their body cues to sleep, and when sleep is enough and not enough. And you can follow some direction from Dr. Poe as we dig into it.
All right, let's get into it.
This is called the two-process model. Process S, which is the homeostatic need for sleep. The longer you're awake, the more pressure is to sleep. And process C, which is the circadian, which is reset every day by light. And it's a circadian drive for wakefulness that wakes us up in the morning, even sometimes when we're still sleep deprived, the drive to wake up. Or if we're sleep deprived and you think, oh, I'm going to be going to bed at 6 p.m. tonight, and you lay there and you can't. Even though you're sleep deprived, you can't, because that circadian drive for wakefulness maximizes in the morning and in the early evening. But in the middle of the day, it slacks off a bit.
Mm-hmm.
And so if you're sleep deprived, you need a nap. You can take it in that middle of the day. But then at night, you've been awake, say 16 hours, that process S takes over, and that process C slacks off, so you can actually fall asleep really, really well.
So even if it were to be light, longer hours, the process S would create a pressure
would still create sleep pressure. Exactly. So good point about, so light is a powerful suppressor of melatonin, which is the hormone of the night, and helps you coordinate all of the sleep things that happen in the first part of the night. And so melatonin, when it's released, is normally about 10 o'clock at night. If you've awakened at 6 with the sunlight, around 10 o'clock, 10:30 at night, your melatonin starts spiking, especially if you're allowed your surroundings to be dark. If you don't allow your surroundings to be dark and you're in bright light,
suppressed,
in surgery or whatever you're doing, your melatonin is completely suppressed. So you do want to dim the lights about bedtime.
Can we have a little tangent?
Yeah.
How dark?
How dark
is the right?
The darker, the better.
Yeah.
The darker, the better, because even just a few photons of light can be enough. Your eye senses it, and it goes back into your brain, to your SCN, which is the suprachiasmatic nucleus. Long name for a very small nucleus in your brain, and what that does is that suppresses melatonin. So you want it dark. The darker, the better. If you have a mask or blackout curtains.
So the phone on the night table, the baby monitor, the light under the door. What about the moonlight coming through the window?
Really interestingly, there's a great study by what is his name at University of Washington. Means of the church, his last name. Anyway, it's a Spanish name. I can't remember. Anyway, he did a great study with people living without electricity, And then, or in villages with just a single light bulb in the ceiling kind of thing versus college students, leading their busy lives. And in all of those groups, what he found is that when there was a full moon, people slept less. And so it's kind of weird because you wouldn't imagine college students even know what phase of the moon it is. They haven't been outside for a while, but still they slept less when it was a full moon. He doesn't know how to explain it. I don't know how to explain it. De la Iglesia, his name is. And so, so it could be light. It could be the gravitational pull when, I don't know of the full moon, but it needs to be replicated, but it was
fascinating.
Yeah, it was really interesting.
Yeah, but you asked about whether a full moon would be enough light to keep you awake.
Could be.
I think there's a variation in how sensitive people are to light. There are people with circadian rhythms disorders that need a full daylight sunlight to reset their circadian rhythm every day. But there are other people who, with just 5 minutes of fluorescent lights in a room, it's enough for them.
Yeah.
So how would you recommend someone navigate that, trying to figure out whether they're light sensitive or not, in terms of how that impacts their circadian rhythm? Is just get up in the morning, get some sunlight.
Right.
Might wake you up, might take a little bit longer.
Well, I think if you can look at children, their circadian rhythms are huge. You can see their drive for wakefulness at 6 a.m. is, they're up, they're awake. You can't tell them just go back to bed, and they actually, even if they're sleep deprived, they won't be able to go back to sleep. So given all the other things that we're going to talk about, sleep is important do not sleep deprive your kids because they can't make it up by sleeping in the morning. So anyway, if you want to look at what an ideal circadian rhythm is and look at children and then see if you, are following such a similar circadian popping up in the morning. If you're not, it might be that your circadian rhythms have been dampened in some way. And if you're on a kind of a free floating circadian rhythm, if you can stay up and then sleep until noon and there's no problem with that, maybe you're very much less sensitive to light. Teenagers may be a little less sensitive to light. I know my husband is a sleep and circadian researcher also, and he's also a physician. And I remember he was counseling parents who would complain that their teenagers wouldn't wake up in the morning. And he said, you know what? Throw open the curtains if that doesn't work. One parent he talked to their son had a room with a sliding glass door, and he said, just pull them out into the sunshine. And that worked. So even the most insensitive person with a bright light of day, will respond. The circadian rhythms will respond.
We recently got bearded dragons who actually are diurnal and will wake and sleep at the exact same time as our kids. Sun goes
amazing.
Down, they're out. Sun comes up, they're up. And we don't even need to turn on the UVB light. They're up with the sun coming through the window. And
that's amazing.
No matter what time we put our kids to bed, they're up also at 6 in the morning. So
that's right.
We don't benefit from that either.
That's great. Your little alarm clock.
So are you able to take us through an average night's sleep in terms of the stages and everything that you would expect the average person to go through?
Right. So say you're going to bed around 10:30 at night, or in this case, it's around 10:30 at night.
Doesn't look very dark in that room.
That guy is not sleeping. That is a stock photo. He's smiling way too much.
Yeah, that's not in your lab, Dr. Poe.
So this is actually the Fitbit monitor from my sister-in-law, Sandy, who was about 60 years old at the time. And so you can see she went to bed around 10 o'clock, was awake for a few minutes, and then fell into the first light blue step right there is called N2 stage sleep. And that's also called transition to REM because you can see it precedes every one of those REM red periods there. And so what that sleep stage is characterized by is sleep spindles, which are these weird little things that last about 1.5 seconds, and they're about 10 to 15 hertz in frequency, and they come and go. And interestingly, your density of your sleep spindles correlates pretty well with your intelligence. Or if you learn something the day before, you're going to have to increase your own sleep spindle density, so the number of them per minute in order to consolidate that thing you've learned. So that's an important stage of sleep. And you can see a lot of the night is spent in that light blue stage. Yeah.
Sorry. Do you mind if I interrupt you? I'm sorry. But so you're saying that if you're learning something during the day, your sleep spindles will be more frequent at night?
Yeah. If you are adequately consolidating it. If you don't increase your sleep spindle density, you actually won't consolidate it. And the next day you'll have to learn it all over again.
Yeah.
We had an awesome question in lab the other day asking, well, if slow wave and REM sleep, which we'll get into in just a minute, are so important, why do we even need N2, this kind of lighter transitional stage? But
it's not lighter.
Yeah.
It's actually not that easy to wake people up out of N2, especially during spindles. So a sound that might wake you up out of slow wave sleep, which we'll talk about next, actually will produce instead in N2 sleep a sleep spindle. So interestingly, you could increase your sleep spindle density by having kind of soft sounds in the environment. I wouldn't recommend it because if you happen to be in deep slow wave sleep, you'll interrupt your sleep instead.
Right.
And we don't know if that sound stimulated spindle serves the same function as an intrinsically generated spindle. So yeah, we don't know that answer to that.
Just highlights the fascination though with trying to optimize your environment to promote, and elongate these different phases.
Objective reads on people's sleep patterns.
Yeah. I definitely, speaking of all this, would not fall asleep with the television on or a podcast playing in your ear. Maybe the first half hour, it's okay. But once you get into that deep slow wave sleep, it could break up your deep slow wave sleep in ways that you're not even conscious of and make you sleep less well. So if you do a podcast, if you're listening to a podcast right now to fall asleep, put a timer on it so it stops.
Good tactic.
Yeah. All right.
So deep slow wave sleep is that deep dark one there. And that is where our brains are actually washing itself. I call it the bilge pump sleep state. So you have big waves of activity that sweep from front to back. And as the brain gets active, the neurons expand. And then when they're inactive at the troughs, so they're about 1 hertz or 2 hertz in frequency. So once per second, you'll get one of these waves coming through. And at the troughs, the neurons are really, really silent and they all contract. So that kind of group expansion and contraction into the extracellular space produces what in my mind is a bilge pump. And because it's sweeping from front to back, it can sweep the garbage in your extracellular space out into your lymphatic system.
And lymphatics, we've probably talked about it on the podcast before, but maybe you can just elaborate on that and what it is that's being swept away exactly.
Right. Yeah, misfolded proteins like tau or beta amyloid proteins, the things that accumulate in Alzheimer's disease, that's being swept away. Interestingly and sadly, as we get older, although there's a lot of variability, the amplitude of those slow waves goes down. So it might be why we are more prone to neurodegenerative diseases like Alzheimer's.
Age
and
is the biggest predictor of neurodegenerative disease.
Yeah, age is, and
maybe that's
also
one of the links.
biggest. Yeah, and that.
And now, I did a podcast with Sarah Mednick, which I mentioned to you before, and she described the duration of slow wave sleep decreases as we age.
Yes.
And she actually described it as the signature. I don't even know we had this. The signature of aging is sort of this decreasing duration of the slow wave sleep. Which is a big deal when we talk about, we're trying to wash out, these misfolded proteins.
Yeah,
right?
Exactly. Yeah. It's concerning to know that, and it might be an interesting indicator of brain age is the amplitude of your slow waves. So if you're 80 years old, but you have big, beautiful, juicy slow waves,
you'll be fine.
You're probably fine.
Cleaning out the
is there anything that you know of that prevents that decreased duration of slow wave sleep as we age? Has it been correlated with a lot of these, for example, modifiable risk factors that we know about that we can modify to prevent potentially dementia in the future?
If we knew that, there would be $1 billion industry.
Right.
However, we do know exercise increases the amplitude of your slow waves. So even as you age, or maybe especially as you age, you should get your exercise, your daily exercise, because that has been known to increase the amplitude of slow waves. So that's one of many.
If you could put
possible
exercise
things.
in a pill, I think everyone
Yeah.
would quickly jump on board.
Absolutely.
That would be a billion-dollar industry.
Yes.
So that's slow wave. And then glymphatics, this kind of pseudo space next to blood vessels in the
Yeah.
brain where there can be flow of liquids that are carrying misfolded proteins, other debris.
Other debris, yeah.
And so that happens with these bigger, slower waves.
Yeah.
That's
So
amazing.
another thing that maybe Sarah Mendick talked to you about, but I can certainly repeat, is there is, during that slow wave sleep, even though the slow waves are once per second, there's a slower cycle that's about once every 50 seconds where a brainstem nucleus called the blue spot, locus ceruleus, actually silences at this rhythm of about 50 seconds and then gets a little more active and then goes silent again. And it's thought that the locus ceruleus, which actually is a vasoconstrictor, is really important for this brain cleaning lymphatic function as well. So there might be, in addition to the slow waves, there is some evidence that there's a once every minute kind of sweeping.
The controllers of glymphatics is going to be the next, 5 or 10 years of neuroscience.
Yeah. It would be, I'm very excited to see where that goes.
Correct me if I'm wrong. I think the glymphatic system in and of itself was discovered relatively recently, right?
Yeah. Actually about 10 years ago.
Yeah, incredible.
We had no idea that the brain had a lymph system.
Right.
Because, in the brains of people who'd passed, it collapsed, right? And by the time people looked at the brains, they couldn't see really, just looked like zero space between.
And structural imaging in a live person is not functional or is not, a moving picture. It's a static image. And so you miss it.
And so there are new techniques that provide a more fluid image that you can actually see the fluid flowing. So,
and certainly in animals.
Yeah.
All right, back to this. Are we done with this?
No, we didn't go into REM.
Okay.
We didn't go into REM. And we didn't point out the fact that it's in the first half of the night that you get all of that deep slow wave sleep.
Slow wave sleep, yes.
So if you deprive yourself of sleep until 2 a.m. and then you go to bed, you will have missed that window for the deep slow wave sleep.
Right. Important to note. You can't make it up by sleeping more into the morning.
You can't, because there must be some circadian control of it as well.
Right. But it's your biological clock. It's obviously not okay at 10 p.m. universally.
You can't just
right.
It's your own biological clock.
It's your own biological clock based off of when you usually go to sleep.
Right. So if you're a shift worker and you're well acclimated to the shift work schedule, you will shift this whole thing to the daytime when you're sleeping instead.
That's really interesting.
It won't be as beautifully aligned because it's really hard to control your exposure to light as a shift worker, because the whole world around you is, in daylight. So you can suppress your own melatonin rhythm quite easily by just, not wearing the deep blue sunglasses, blue blocking sunglasses.
So just to kind of piggyback on that chronotype, if someone is a night owl and going to bed at midnight, are they getting that first phase of deep sleep? Or
if you're there's no good evidence that let's just put it this way. Once you do wake up and expose yourself to light, that's when you're resetting your clock too. So say some people wake up at 6, some people wake up at 9. Those who wake up at 9 probably have a well-shifted circadian rhythm because they're got their blackout curtains or their sleep masks or just a dark enough room that they are not resetting that 6 a.m., their clock to 6 a.m. Instead, their clock is set to 9. And so, they could probably shift it. It doesn't seem to be infinitely resettable unless you, again, really control your outside exposure to light. But
what about, can we piggyback off of that with jet lag?
Yeah.
What do you think about jet lag? How does that influence slow wave sleep?
Yes. So the best thing to do, advice that you can have is expose yourself to the daylight of where you're going. You can try and preset yourself so that when you land in wherever you're going, you'll be already a little bit circadian shifted, just like a shift worker might do. You can try and preset it for a couple of nights because, in fact, our circadian clock turns out can only shift about 2 hours a day. So if you're going to go around the world to the other side, it's going to take you 6 hours at best 6 days at best to shift to that new light dark cycle. So, yeah.
I've experienced that.
Yeah.
I think we'll come back to sleep banking, but that reminds me of that. Why don't we finish off with REM here?
So then you go from deep slow wave sleep into REM, and that's where our brains are as active, cognitively active as it is when we're awake. So if you wake someone up out of REM sleep, they will almost always report having dreamed, and their dreams will be vivid, like they've been living it. Yeah, so it's interesting that some people don't, but it's a very minority of people and a minority of the time that people won't have retrieved a dream when you wake them up out of REM sleep. And that might have to do with something else we might get to, which is how different parts of the brain can be in different sleep states at the same time. So it might be that your cortex is saying you're in REM, but your hippocampus or other areas are still in slow wave sleep. So you won't have recorded in any way that dream.
Right.
But anyway, we're skipping ahead. So that's the state where we're dreaming. It's really an exciting and fun time. And we don't know, that's the state where you stop thermoregulating. A lot of things go really wonky. We're completely inhibiting our muscles. And so if you wake up out of REM sleep the wrong way and you don't fully wake up, your brain could still be actively inhibiting your muscles and then you're paralyzed. That's not adaptive, right? It's also a pretty deep state. It's not easy to wake people up out of REM sleep. I mean, it's not impossible, but it's not easy. So it's a very vulnerable time, and its function is still, being worked out. But we have some clues about its importance.
Can we just go down a rabbit hole here regarding dreams? I've always wondered, just for myself, but, also for my patients, if we should really be focusing on the content of dreams. And maybe I'm getting a little bit too philosophical here, but just in the sense of, is this our subconscious trying to communicate something that is important to us, that is difficult for us to communicate in consciousness, for myself, but also for my patients, right? Like, especially my PTSD patients. Tell me about the dream. What is the content? What's going on? Really delving into the details.
Yeah.
Is that even worth it? What do you think?
I think it's worth it.
Yeah.
I think it's worth it because at least I think most of the time our brains are sort of freewheeling during REM sleep in a way that we don't allow it to when we're awake. So there are thoughts and images and connections that we can make during REM sleep that our logical brains, won't let us do. And so what comes up during that state, if you can remember it during the daytime, should be analyzed. What is happening that I'm not paying attention to when I'm awake? And what is important about that? I know for me, I've had dreams of tornadoes or spiders, and when I wake up and think about them, I can identify something in my life that is out of control with a tornado or dangerous in ways that my conscious mind just was unable to even recognize.
Yeah. I was reading some of the work you've done, and I think you wrote an essay or a paper alongside another author where you guys discussed the next up interpretation of dreams. Honestly, I read it and I was trying to understand it. I told my wife what I thought the theory was, and she's like, "No, it means this." So I'm going to read it, and hopefully maybe, or you can just maybe tell me what the theory is.
Happy to. Great. This is not my theory. This was Bob Stickgold and Antonio Zadra.
Right.
I think it's a beautiful theory, and it's been theorized, as they say in their book, from thousands of years, that dreams are actually helping you work out problems and play scenarios that you haven't experienced in order to sort of play out what would happen if I did this. Like, I've had a dream where I cheated on my husband, And, the end of the dream was pretty bad.
Right,
That's not worth it. Not worth it. So,
That's such an awesome
yeah.
example.
So I think that's what the next hypothesis is, or theory of what dreams do. They help you play out things in a safe space that you don't actually have to try in the real world.
Right.
And see how it goes. Now, I mean, that wouldn't be true of my flying dreams. My flying dreams are great. I love them. I don't want to say, oh, that means that I can fly if I jump off a building. No, you don't. You don't want to lose your logical mind as well when you're awake. But
the way that I assessed it, and you can tell me if I'm incorrect, but your brain is trying to determine whether there's any emotional attachment to this experience that is presenting to you, and what your brain is actually doing with that information. I didn't really understand. I didn't really know.
REM sleep is a time when our brains are super plastic. So it's highly suggestible. People try to replicate this with psychedelics, for example. But our brains are really, really capable of forming new connections and breaking apart connections that are no longer working for us, no longer serving us normally anyway. So that area, that blue spot area I told you about in the brainstem, that is on and off in sort of a 50-second cycle during slow wave sleep, turns completely off during REM sleep. And what's good about that is that area, that blue spot, that when it's on, which is all the time we're awake, helps us learn things, but doesn't ever help us let go of things that our brain needs to let go of to form a new schema or to integrate something new into our schema in a coherent fashion. So during REM sleep, it's off, and our brains are really free to completely renovate the way we think about the world.
Right.
Normally.
Yeah.
Normally.
Incredible.
Do you want me to tell you what happens when it doesn't turn off?
Absolutely. Yes.
All right. So there are times of the month when women's or female brain that locus coeruleus doesn't turn off completely. And so then our dreams could help us certainly learn quite easily, but it doesn't allow us to let go of things and reshape our schema in light of new information. So it's possible that this is one reason why women are more susceptible to getting post-traumatic stress disorder. And people with post-traumatic stress disorder, it seems like their locus coeruleus never shuts off during REM sleep. So all dreams are only serving to reinforce that initial traumatic memory again and again and again, sort of digging you deeper and deeper into the entrenchment of that traumatic memory.
Without the locus coeruleus on, without norepinephrine kind of coursing through the brain, do you think nightmares wouldn't have as much of an impact, potentially would even play out and cause an type of exposure therapy or habituation or extinction?
Absolutely, yes. And that's, again, one good thing about normal dreams is that they're so bizarre that even if we're dreaming about something that happened in our past, usually there are new elements and things that we're tying into it to help us to put those memories away in the rest of our brain, and then to weaken the memory from our immediate memory structure. So we have put it away, and then we can clear it out from our initial memory structure, which is called the hippocampus. And so the bizarreness of dreams can help us make new connections and get us out of the trench of the original memory. So often, I don't know, you can tell me, but people with post-traumatic stress disorder hate their dreams because they are dreaming about the traumatic memory again and again, the same thing over and over again. And everybody who goes through a really bad trauma has nightmares about that trauma. But part of the normal process of recovery is that those nightmares incorporate other elements that help resolve and put them into the long-term memory structure.
Yeah.
So then you can erase them from the short-term memory structure. It's not as immediate.
So without norepinephrine, in that case, potentially those connections to the memory would lessen over time.
Yes, especially the emotional ones. But actually just it clears out. Our hippocampus is a temporary learning space at which everything we learn during the day gets dumped into the hippocampus. The hippocampus during sleep translates that and puts it away into the rest of our brain, after which time REM sleep can erase it from this novelty encoding structure and leave us free to learn new associations the next day. So exposure therapy or, in a safe context can be made, those associations can be made in the fresh, clean hippocampus the next day. If your hippocampus never gets a chance to clear itself out, it doesn't have the synaptic space to do that new learning and make those new associations the next day. So you really need that time to offload the memories.
So what norepinephrine is doing, it's solidifying those connections and
Yes.
or those memories, and not allowing you to, in the practical sense, move on.
Yeah, exactly.
What does it look like when REM is disrupted in the aftermath of adversity or trauma?
Yeah. Well, it interesting looks like a lot more active REM, more phasic REM. So you'll have more twitches, more body jerks, more eye movements, more cries, and more brief arousals or long arousals, because you wake yourself up out of this state. And we don't yet understand how or why abnormal activity in the locus coeruleus allows us to overcome the atonia in REM sleep more often. But there is a really intimate relationship between the areas of our brainstem that inhibit our muscles when we're dreaming and the locus coeruleus.
So that is not necessarily when someone would have PTSD, but in the process of, ridding itself of those memories and moving forward.
Yeah, like I said, or maybe I didn't say, but after a traumatic event, everybody, it looks the same, pretty much.
Yeah.
And that is disturbances and nightmares. And, but interestingly, in our animal models, non-human animal models, we can't study this as well as we'd like in humans because, of course, we don't want to cause anybody a trauma. Right. So anyway, in our animal models, what you can see is that those animals that go on to get PTSD, and that's, you don't call PTSD until some time has passed.
4 weeks after, clinically.
Yes,
at least.
4 weeks after, because everybody in the first few weeks are disturbed.
Right.
But then you can see whether it's a disorder or not after a month or so. And so people who go on, or animals that go on to have all of the symptoms of PTSD in the first sleep after that trauma have about double the amount of rapid eye movement sleep.
Wow.
Whereas those who are resilient decrease, especially in the first few hours. They decrease almost no REM sleep in the first few hours.
Wow.
And it's as though they need to allow their brains to come to some sort of resolution about the trauma that happened to them, like learn from it, for example, what not to do next, before that learning signal feeds back to our locus coeruleus and allows it to say, okay, I've learned my lesson. I've learned what not to do next time, if there's ability to do that, or what to do next time. Our locus coeruleus can calm down. And then when we go into sleep, our sleep can be normal and the locus coeruleus can be silent as it normally should be. If we go into REM sleep and even more REM sleep before our locus coeruleus is able to have that feedback calm down signal, then it serves to only reinforce and re-entrench that traumatic memory.
So, those are two distinctions that you're able to make potentially with more resilient individuals where they have less REM sleep in the aftermath of a trauma relative to maybe some people that would be regarded as not so resilient. Their REM sleep will increase.
Right. Yeah. Interestingly, and this is, again, we haven't been able to study this in humans because get someone
immediately after
to sleep with some electrodes on them immediately after a trauma just hasn't been done. But there are later signals that sleep has been altered, and that is disturbed REM sleep, not less REM sleep in people with PTSD, but much more broken up.
Much more broken up REM sleep. Yeah.
On a more subtle kind of day-to-day scale, do you think there are ways that you can create that calming signal to the locus coeruleus so that at night REM could be more refined and proper?
Yeah, I think this is the key. The locus coeruleus is kind of the heart of the sympathetic nervous system, which is the fight or flight, the react. So the opposite side of that is the parasympathetic nervous system, which is called rest and digest. And so if you can figure out a way, even if you have, whether it's a recent trauma or just a regular day, or an ancient trauma that you just can't put to bed, then what you should figure out through trial and error is whatever it is that makes you the most relaxed before you go to sleep, because that rest and digest relaxation is the parasympathetic system dominating over the sympathetic nervous system. And so people have tried various things, and I'll tell you a few of the ones that to me I wouldn't do, like cold ice baths. They dunk themselves in a cold ice bath for as long as they can stand it.
Which jacks up the parasympathetic?
It jacks up the sympathetic.
Does that relax them? That relaxes
it's not
them.
relaxing. It completely is not relaxing. But then the rebound from that, when they get out of that cold bath and into the nice warm shower, is a parasympathetic rebound to that sympathetic activation. It's almost like hitting the red reset button. So that works for some people. Other people, and for everybody, what should work is your brain able to come to a conclusion that then calms your locus coeruleus. Like, for example, yes, this horrible thing happened today, but I believe that in the end, it's all going to be okay. And I'm going to give the burden of this to the universe or God, and God will take care of it. It's not something I don't understand why this happened to me. Maybe there is nothing to be learned from it, but I'm putting my trust in God or whatever it is that ultimately it's going to be okay. And then you can breathe again and relax.
Yeah.
But I don't want to blame people with PTSD. I don't want to say it's because you don't have enough faith. That's not what this is. That's not what this is. It's just finding what it is, the magic formula for you. And for people, some people might be prayer, some people might be meditation, some people might be an ice bath and then a warm bath, or it might be coloring, or it might be watching a funny show, or it might be, I'll not mention some other things that are very calming to people, unless you want me to. I'm not embarrassed, but yeah, some things that really help calm you, and whatever the magic formula. Oh, not alcohol though. That's what a lot of people use. Is they say, oh, alcohol knocks me out, and it certainly does shut off your prefrontal cortex. And if you've been ruminating or worrying about something, you stop worrying about it, but that doesn't allow you to have normal sleep.
Yeah.
And so it doesn't allow your sleep then to do what it's supposed to do to set you on the right track.
If I may, what about marijuana? They got a lot of patients with PTSD that they use marijuana to help them go to sleep.
Yeah.
What's it doing to our sleep?
Yeah, that's a fascinating question. About 10 or 15 years ago, there was a poster at a meeting that I saw that used CB1 agonists, which is, it's a cannabinoid receptor 1 agonist. And what that did to sleep in a rat, and it completely eliminated their REM sleep.
Wow.
It completely substitute REM sleep with that spindle state, only the spindle frequency wasn't like a blip, it was just constant spindling frequency. And so maybe one reason why it helps people with PTSD get to sleep and sleep more relaxedly is it eliminates their
REM and their dreams.
But that is not a path for wellness.
Exactly.
It doesn't allow REM sleep to do what it's supposed to do, which helps you resolve those emotional memories and put them away.
Yeah, that's great.
But actually, so I saw this like 10 or 15 years ago. I hadn't seen the paper published. Kept talking about it. I kept thinking about it, kept thinking maybe I should just reproduce this study. It just came out in, I think last month, that it reproduced in humans.
Wow.
That it does the same thing. It completely eliminates REM sleep and
That's
substitutes
fascinating.
the frequency.
So, thinking back to the kind of REM physiology and thinking about waking life and sleep as a transition, and what you do in waking life somehow affects your sleep, and what happens in sleep affects your waking life. Are there things you can do physiologically, like breathing prior to bedtime, that will somehow enhance REM?
Right. Enhancing REM is enhance good quality REM is what you're talking about. Yeah.
So can we define what that means?
You're right.
Can we define what enhancing and
Enhancing
it sounds
REM.
like good REM probably means inactivating that locus coeruleus
Yeah.
that you're not releasing norepinephrine.
That's right. That's right. Yeah. So good REM is characterized by a whole lot of things, including a really strong activation from another area of the brainstem right next to the locus coeruleus, which is called the subcoeruleus, inventively. But that contains these big excitatory neurons that turn on during REM sleep and probably are the instigators of our dreams, because they project all over to the brain too, and they cause these storms of activation that then allows you, I think, because they seem random, they may not be random, but anyway, it seems like a random sort of set of neurons are activated, and then you can make new connections in the cortex. So that's one thing that you would need for good REM sleep. You need the silence of the locus coeruleus, silence of the serotonergic system, which differentiates real REM sleep from psychedelics. Psychedelics turn on. Nobody really understands what psychedelics are doing, but we do know serotonin and serotonin receptors are part of it. Fortunately or unfortunately, there are like 24 subtypes of serotonergic receptors, and each of them do a different thing. So maybe one psychedelic is activating one set and another psychedelic another set, or whatever.
You have parallel sleep or sleep state to a psychedelic experience, not identical, but I think I've heard you kind of parallel those two.
Yeah. I think it's the power of resetting our minds. REM sleep has that power normally, and so you don't need to take a psychedelic. Usually every night is a psychedelic state.
Right. That's a great way to look at it. Yeah.
So heart rate increases, respiratory rate increases, but temperature drops?
Yes. Our temperature, well, it depends on how hot the room is you're in. If you're sleeping in the desert, probably your temperature rises, because in fact, you stop thermoregulating and your body temperature drifts in whatever direction the room is.
Okay.
Room is. So that's one of the reasons why REM sleep is so vulnerable and so difficult to get. I don't mean difficult to get. What I mean is you actually have to have all the right things in place to get into REM sleep. So your body temperature has to be in a good thermoneutral zone in order for your body to allow you to go into REM sleep. That's just
what's the temperature range that you recommend someone, you hear about this a lot. Yeah.
I think this depends a little bit on your metabolism, which depends a lot on your hormones. And so, like men and women usually like the room temperature to be slightly different, although that's an overgeneralization, because in fact, women have a cycle, and some parts of the cycle, they might want the room to be cooler. In other parts of the cycle, they might want the room to be a little warmer. As we get older and we lose our subcutaneous fat, and we have more difficulty thermoregulating, and in fact, your thermoneutral zone goes up. So without that insulation of fat. So it depends on your age, monthly cycle stage, and how much hormone you have. Because even in men, there's testosterone, it's fairly constant. But actually, testosterone changes quite a bit also with various stages and events of life. So I can't give you a temperature, but I know my husband likes it no warmer than 66 degrees.
Right.
And at that temperature, I'm huddled under the down comforter. So for me, it's more like 70 degrees is my, when I go alone and travel and set my thermostat in the hotel and my husband's not there, it's 70. But yeah.
Incredible. Yeah.
So I think that brings us to sleep hygiene. We've been talking in and around it after we've gotten to know the stages. And we've been thinking, I think, about how to optimize these different stages and get the most out of sleep. But when going through all the things that I've heard recommended, I wonder if we could throw a few at you and you respond. So time to go to sleep. We talked a little bit about it. Does chronotype play a role in your thinking about sleep? Can you actually replicate that in animal studies? Is there such a thing as chronotype?
Yes, there are. And that has to do with the length of your own intrinsic circadian cycle. So some people it's a little less than 24 hours. Some people it's a little more than 24 hours. And most people it's a little more than 24 hours. So that light, resets you to 24 hours every day. So what was your question about?
Chronotype, is there such a thing? I mean, has it been studied in animals with good science that you know of?
Yeah. Is there chronotype? Yes, there does appear to be chronotypes. Interestingly, night owls, of which I tend to be more of one, don't live as long, unfortunately. So, but we haven't studied whether or not if you fight against that chronotype and go to bed at have to wake up at 6 every morning for your job or whatever, whether that then helps you extend your life or it might be that those who are really especially extreme night owls, the problem is not their chronotype so much as that it's disalignment with the rest of the world. And so when they are obeying their chronotype and staying up late, but the world still makes them wake up at 6 in the morning to go to their job, they're actually more chronically sleep deprived and more variable in their sleep onset time, which has been shown to be correlated with longevity.
So consistency matters.
Consistency matters, yeah.
What about melatonin? Supplementation. I think I heard you allude to there's certain lifestyle modifications and behavioral things that we can do that might influence the amount of melatonin that's released at night through our circadian system.
Yeah. So resetting your circadian rhythm in the morning is with light. Bright light is a good way to help increase the amplitude of your melatonin surge at night. Darkness, you need darkness. Probably start dimming the lights by like a half an hour before you actually want to go to bed. So, maybe brush your teeth in dark. I don't know. Or maybe a red light at least, not a blue light. And if your bathroom night light is blue, switch it with a red one because blue light is more effective at suppressing our melatonin rhythm. So, and then everything that helps your whole hormonal system be, again, that all sort of dampens as we get older, but there are things that you can do like exercise during the day that helps you release more growth hormone at night and also more melatonin. So anything that helps deep slow wave sleep will help also melatonin because the two go hand in hand. So
what about supplementation?
Oh, supplementation. Yeah. So the problem with that right now is that everything you get over the counter is not regulated by the FDA and there's a great study that showed, I think it surveyed 17 different melatonin pills and gummies and found that some had zero the amount of melatonin while others had 10 times as much melatonin as you would need. And so I don't know if that varies pill to pill. They didn't go into that, but between the different kinds of supplements, it was just wildly variable.
Yeah. You mentioned a study, something that came out of the AAN regarding melatonin.
Yeah, it continues at the annual meeting for neurology. It continues to be a debate. It's one of those things that's easy to prescribe or recommend. It's over the counter, doesn't have much adverse effect.
Right.
And so I think neurologists like to have something to provide for sleep that doesn't cause, some type of lethargy during the day or cognitive dysfunction. But at the end of the day, I think there's two camps. One that says you're actually stunting a system, and the other that's saying, this is
you're helping
helpful
out.
thing. Yeah.
So your own melatonin, you're young and healthy. Your melatonin is great. You don't have to worry about it. You don't have to take a supplement unless you're, trying to cross a bunch of time zones and trying to reset it. That might help for that. So I wouldn't recommend it for a young, healthy person. I don't know if I want to say this. Somebody's going to be mad at me, but in fact, if you think it helps you and you're young and healthy, it's probably a placebo effect. but go for it.
Mm-hmm.
Placebo effects are strong, right? They work 33% of the time.
Mm-hmm.
So it's inexpensive and, like you said, not unhealthy way
Mm-hmm.
to help yourself get to sleep.
Mm-hmm.
For older people, the melatonin rhythm is dampening. So it could actually help people who are older. But again, problem with the supplements is.
Yeah.
So actually, I mean, if you do have insomnia and you're older and you want to try melatonin, I would actually recommend going to your doctor and getting a prescription for a melatonin receptor agonist rather than the over-the-counter melatonin, because that, what's in the pill.
That's interesting. That's a good recommendation. Yeah.
Other common sleep hygiene things.
You wanted to ask about sleep banking, I think.
Yeah. Well, in general, catching up on sleep, sleep banking, sleep extension, napping, maybe we go there.
Yeah, there is no savings account for sleep. Sadly, you can't, but you can get to zero every night. You can get to, from the deficit to zero again.
Right.
You can't bank it. You can't get into the positive. You can't save up sleep. But if you start at zero and you start you're going to have to do something in the next month, you're only going to get 4 hours of sleep every night. Before that month starts, get as much sleep as you can, be sleep sated, because the longer you're sleep deprived, the more sleep deprivation builds up. Sleep can't build up, but sleep deprivation builds up. So if you start at zero, where you're completely sleep sated, your functionality the first day of a sleep deprivation will be better than if you start already sleep deprived and then you're sleep deprived again.
Mm-hmm. So you're working against the kind of sleep deprivation.
Build up.
But that's what banking is, right? You're pre-sleeping before, let's say.
But you can't sleep more than your body needs. So you can't pre-sleep. If you can nap and you can sleep 14 hours a day in order to bank sleep, that means you're making it for past deficit.
Yeah. So,
Mm-hmm.
but what? Okay, you sleep a lot, then you become sleep deprived one day, but then that's it. You're sleep deprived at that point, right? It's not like, oh, now because you slept so much the day before, you
can't draw down the bank. No.
It's like
you're sleep deprived, but the degree of sleep deprivation.
Sleep deprivation. Okay.
Yeah.
All right, cool.
So say you've had 5 days of 6 hours a night, you'll be a little bit sleep deprived, and then if you start another 5 days of 4 hours a night, that sleep deprivation that deficit will rise faster than if you start
without a deficit.
Without a deficit, and you do 4 hours a night, you'll end up like at the end of the 5 days with.
So essentially, before a big trip or something like that, don't deprive yourself.
Yeah.
Sleep 7 to 8 hours or the normal amount.
Yeah, that'd be great if you could do that. However, on the other hand, that process S, that homeostatic drive for sleep, could help you go to bed at the new time zone. If you're if you're going to be jet lagged, you're going to a new time zone. I actually often just not planning to just have so much to do before a trip that I stay up really late, or maybe not go to bed at all, especially if I have to fly early in the morning, so that by the time I land, my process S is really strong. And if, say, I've flown to the East Coast, night is 3 hours earlier, normally that would fall in a time of my circadian no-go zone, no-fly zone. But I can, because I've built up this sleep debt, I can fall asleep like a baby. Yeah.
You mentioned napping.
Yeah.
I've heard you say that you nap.
Yeah, I love to nap.
Do you advocate for, most people are tired in the middle of the day after lunch, take a nap?
Yeah, definitely. There's the power nap, which is 20 minutes.
Okay.
That's good to restore your metabolism, better than a cup of coffee, because coffee just fools you into thinking that you've slept. But sleep actually does the work that your body needs, and it's driving you to sleep. Or if you can take a whole 2-hour nap, where you're just luxuriating and you go through all the sleep states, including REM. And then Sarah Mednick's book and articles show that can be for cognition as good as a whole night's sleep in terms of refreshing your memory and putting things away. So
how should you strategize, or what's the kind of science behind what napping is doing, 20 minutes versus 90 versus 2 hours.
Yeah.
Like, what are
So-
you actually doing during that
Yeah.
time?
So those sleep states that we went over earlier,
Mhm.
it's about 40 minutes into sleep that you've hit that deep slow wave sleep. If you try to wake yourself up out of sleep, deep slow wave sleep by setting your nap alarm or, having something you have to do, you're going to feel horrible. You're going to feel groggy. You'll have sleep inertia. It's called sleep inertia. And the analogy that I like to use is it's like trying to open the washing machine when it's full of water and it's churning away, cleaning your clothes, and try to pull the clothes out and put them on and walk around. It's like you need to go through the rinse cycle and you need to go through the dry cycle, which
there's a really funny meme out there where it's like, oh, when you take a nap in the middle of the day and you wake up and the picture's like a hibernating bear coming out of the cave, like all disheveled. It's just very funny. And some pop culture reference for you.
Yeah.
But, sorry, go ahead.
Yeah. So that's why the 20-minute nap is you're in N2 stage. You're in that stage, your mitochondria are churning out the ATP or, fuel for your brain, your whole body. And and actually a lot of those sleep spindles, there's some really interesting things going on in your cortex that are actually helping to consolidate the things you learned during the day. So it's helping to stabilize your memory. So 20-minute naps are great. But if you slip down that slope into deep slow wave sleep, your nap has been too long, unless you make it a 2-hour nap and you've gone all the way through the dry cycle of REM.
Right. I wonder how this plays into the timing of when we wake up just from regular sleep.
Yeah.
Right. So certainly sleep inertia isn't only applicable when you nap, but when you're getting a full night's sleep.
Yeah.
What do you think about sleep inertia relating to maybe when people are getting up in the morning feeling much more groggy than usual? Should that dictate when we actually wake up? What do you think?
Yeah, I think if you wake up groggy and just want to go back to sleep, go back to sleep. If you possibly can. Nudge your wife, say, you're taking the kids to school today. I've got to sleep a little bit longer. And chances are the next time you wake up spontaneously, you'll wake up out of REM.
But so when you're planning your sleep, right? So you're like, I want to make sure I don't wake up in the middle of, my peak sleep inertia.
Yeah.
Like how many hours is that? Is there any way to be able to tell that?
So the rough, sort of back of hand thing to do is, on average, sleep cycles take 90 minutes. And so you just calculate in 90-minute increments and you'll probably wake up out of REM. Yeah. Although just to caveat, in the first part of the night, they're a little longer, like 105 minutes or something. And in the last half of the night, they're a little shorter. But on average, if you plan it out every 90 minutes.
We've got this study going on here right now that I've got an Oura ring on everybody. We're doing a lot of MRIs. This is in the chronic state of concussion. And obviously we get sleep efficiency, duration of each stage, and so on and so forth, as good as the device can do. But I wondered about the pattern. Do you always hit slow wave within 20 minutes? Do you always hit 4 or 5 REMs a night? And if that variability would in any way predict symptoms or recovery or response to treatment? Is the pattern, in other words, meaningful? Because a lot of people have Fitbits or other devices, and you could look at that visually and say, my pattern is consistent day in, day out, or it's not.
Yeah.
Does it matter?
Yeah, I think the pattern does matter. And in fact, with brain injury, people usually get a lot more sleep or need a lot more sleep. And it's thought to be that type of sleep that they're getting, you could tell me probably, is that deep slow wave sleep. And that's another time when our immune system is really being active. And what happens with brain injury is you cause damaged tissue and that needs to be cleared away. And your immune system is activated and trying to get back to normal. So it's interesting that there are some studies that showed the more you need sleep after brain injury, the more deficits, the longer the recovery, the more deficits you're going to show.
It's more of a reactive index that the injury had caused more problems, rather than that being a mechanism. More sleep is causing worse
Right.
symptoms.
Yeah. The sleep is not causing the
Right,
symptoms.
right.
The symptoms are causing the sleep. Yeah, exactly. And so sleep is trying to do its job in cleaning up your
Right.
brain.
Yeah.
Yeah.
The question is, should you let that happen or not?
Yeah. So there was a really, I love these studies by Rachel. I forget her name. She's at University of Colorado Boulder now.
Okay.
Fantastic series of studies with mild traumatic brain injury. And what she did is she gave rats mild traumatic brain injury, then gave them an NSAID that actually particular of the brain swelling kind of things. And she prevented brain swelling, and that knocked sleep back down to normal in those animals, and their cognitive recovery was much, much better.
So suggesting neuroinflammation, which the longer slow wave sleep would have been trying to do on its own, but this augmented or expedited the process.
Yeah.
Fascinating.
That is really interesting.
So, she gave other NSAIDs that didn't knock down the sleep to normal, and the animals didn't recover as well. So I know there's a few steps in the inflammation pathway that are especially good to target.
Since we're talking NSAIDs and brain injury, chronic pain.
Yeah.
Or just pain in general.
Yeah.
Lots of my patients, not lots of PTSD patients also have concomitant chronic pain and pain-related symptoms. And their pain keeps them from sleep.
Yeah.
So I'd be interested to know what your take is on what pain is doing to our sleep.
Mm-hmm.
And then also additionally, people use opiates to cope with that pain and allow them to sleep better. So what are opiates doing to our sleep?
I'm so glad you asked that question. It's really, really important. And it's a big problem. Big, big problem. So pain definitely disturbs our sleep. All of those sensations go to that locus coeruleus and wake us up, say, something's wrong, so our sleep is less good. And also interestingly, and this is probably a circadian thing, our pain is worse at night, about twice as bad as night. So our threshold for pain gets lower at night. So people feel like they need even more to take an opiate or whatever it is.
Is there a physiological correlate to that? I thought that it's just that everything else, all the stimulation during the day is quieter and the mind goes to the most salient.
That's a great point.
Is there something physiologically that?
No, it's not sleep itself. It's the time of day. It's probably circadian. So has nothing to do with the outside world, although that is an excellent question. But there's been a lot of studies and they all agree in all kinds of animals, including humans, that pain is worse at night, and it's probably circadian regulated.
Wow.
So the problem with opiates is that they don't allow us to have normal, good sleep. The opiate-induced sleep is not doing all the things for our brain that sleep.
Does it hit one phase or stage more than another?
It suppresses REM sleep.
So since we're talking about medications impact on our sleep, I have to ask this. A lot of people with PTSD, a lot of people with mental illness are on SSRIs, SNRIs. We've discussed how norepinephrine has to be absent in certain stages of our sleep in order for us to get really good quality sleep, especially in people after they've been in any sort of trauma.
Yeah.
And, an SNRI is a serotonin norepinephrine reuptake inhibitor. It increases the levels of serotonin and norepinephrine in our brains. What do you think about, being on these medications and what these medications might be doing to our sleep architecture?
Yeah, I think if you have PTSD or insomnia, you probably shouldn't be taking them, because anything that keeps norepinephrine, which is the locus coeruleus neurotransmitter, out there will, prevent sleep from doing what it should. Actually, the SNRIs, SSRIs, and selective noradrenaline reuptake inhibitors prevent REM sleep. They actually knock it down. But having said that, I think if you have depression, obviously it does a lot of good, right? So PTSD and depression are different things. But if you have depression, probably that your noradrenergic and serotonergic systems are a little different. at baseline anyway. So since it seems to work, I wish there was something better, out there.
Right.
And someday we will find something better that doesn't disturb your REM sleep and helps you have normal, good, healthy REM sleep.
Yeah, I felt you would say that, but let me push back a little bit.
Okay, yeah.
Maybe acutely after trauma, it's not indicated because this is the time where you're determining adaptive versus maladaptive sleep patterns that might indicate where you end up in terms of whether you get diagnosed with PTSD or not. But after the fact,
right?
Would you say it might be?
So if you've had PTSD for a while now and you can't see, you're not on the road to recovery, and you've tried everything to get normal sleep, then it's certainly better to have that.
Yes.
And no REM sleep than maladaptive REM sleep. Right. So, yeah.
A rock and a hard place.
A rock and a hard place.
And I think that's a lot of the cases, especially with chronic pain PTSD.
Yeah.
I want to go back to something you said before that was pretty intriguing about parts of the brain being in different stages of sleep at the same time. What happens? When does that happen?
Yeah, that happens normally. In rats where we've studied it, it's about a third of the night of their spending where one part of the brain is in one sleep state, another part is another sleep state. We used to think we'd go in like that chart that we looked at from wakefulness to N2 to deep sleep to N2 to REM sleep. And the whole brain is doing that and the whole body is following along. But in fact, normally in humans, about a third of the night is spent where one brain area is in one state, like say your hippocampus is in REM sleep and your cortex is in non-REM stage 2 sleep spindles. And so actually with these cup electrodes that are the gold standard for sleep, sure, that's the gold standard for cortical sleep, but what about what's happening underneath? And we don't know. We don't know what's happening. And what we, from the studies now that we've done, about a third of the time, those subcortical areas are doing their own party, their own thing. And we don't know the function of that. We don't know if that's a good thing or bad thing. If you're lucid dreaming, that means that your two areas are in two different states. Or if you're lucid dreaming, that means the two areas are in the same state. We don't know the answers to these things yet. We can't ask animals what they're dreaming. So we have to do this in people. And the only time we can know in people whether a subcortical area is asleep is with depth electrodes. And so it's a very small portion of the population that have those, but it could be extremely valuable to do those recordings and to do those studies.
Yeah, fascinating. Hey,
Yeah.
why don't, if you don't mind, you take a look at some sleep staging from a few nights ago.
That's
from
gorgeous.
a random person not sitting at this table.
Yeah, that's my sleep from a few nights ago. So, I sleep. My wife calls it pillow face syndrome. As soon as my head hits the pillow, I'm asleep. It's very quick latency. It's frustrating for her, but it's something I look forward to all day long.
Yeah.
And it's glorious. I do feel fully awake and energetic during the day.
Yeah.
So I don't feel like I'm falling into that insomnia category where this sleep latency is a problem. But anyway, this is what it usually looks like for me.
Beautiful night's sleep. I say, you go to bed at 10:15, something like that. You're waking up at 6:30 in the morning, 6:40. That is a beautiful night's sleep. Look at all that REM sleep you're getting, that light blue in this one. There's one, that second REM period, it looks like you woke up a little bit. Do you remember?
That's a good question. I remember, why I woke up. It was probably the 2.5-year-old down the hallway.
Yes. Okay.
I don't remember what I was dreaming at the moment, but it looks like I had another awakening out of REM in the morning at 6:30 or so.
Yeah. It looks like you, again, once you get back to bed, boom, you're asleep again. That's a beautiful night's sleep.
Yeah.
Well done.
And that's I think you've talked about awakenings before. A lot of people worry, I got to get up, I got to go use the bathroom, I got to do this. And from what I've heard, your take is that's not really necessarily a bad thing as long as you're able to go right back to sleep and resume that stage that you were in before, which it seems like.
And again, don't
Kevin
throw on
is
that bathroom light to full mast, because especially if it's in the first half of the night. But I'd say don't worry about that. That's fine. If you do wake up and find yourself ruminating and worrying about something. What I do is I get up and I do something to help resolve it. And that helping resolve it calms my locus coeruleus again and helps me go back to sleep. Unfortunately, that sometimes is 6 a.m. and then I only have half an hour.
Yeah.
But it's all right.
Yeah.
A little bit of that calm sleep is better than nothing.
Real quick, so this is Monday. So did you go through all your sleeps for every night and pick out the best one? That's what I feel you did.
Well, no.
You definitely went.
Cheating.
You looked for the best sleep
picking.
Performance, and that's the one you brought up.
No, that's one thing I've got down, and it's lucky. I don't think I don't know how to replicate it.
I
for
think it's
anybody else,
really
but,
fantastic.
Let's.
How do you sleep?
How do I sleep? I sleep same thing as him. As soon as my head hits the pillow, I'm out. My boy, 2-year-old, always comes and bothers me in bed at about 1 or 2 o'clock in the morning.
Yeah.
It used to bother me and wake me up, and then I go right back to sleep. But now I don't even wake up. Like I just wake up and the guy's there sleeping next to me. So it's just
that's beautiful.
Yeah, I think we have it down so far. But I think this would probably be a good transition to talk about these trackers, right? What are your thoughts on the trackers? Is this guy actually getting 28% of REM sleep?
They're not bad actually. They're not bad because our peripheral system where these trackers are tracking, follow along with our brain. I mean, they are controlled. Our heart rate is controlled in part by our brain, a good part by our brain, and so it becomes, and our respiration, those things become really even in that deep, slow wave sleep state. So if you have beautiful heart rate variability that varies with every breath you take, you're probably in that deep, slow wave sleep state.
And heart rate variability is a good metric for
a lot of things.
A lot of things.
Actually, yeah.
But I think it's a good measure of our autonomic nervous system, the balance of our autonomic nervous system, particularly that sympathetic nervous system, which could be involved with the locus coeruleus releasing that norepinephrine.
Yes, exactly.
Heart rate variability you expect to be high during REM.
Real relaxed. Actually.
And during REM or?
REM, okay, so REM, so heart rate variability being large is good because it's called respiratory sinus arrhythmia. So your heart rate speeds up every breath you take in and it slows down every breath you take out when your parasympathetic system is mostly in charge. And during REM sleep, with your sympathetic system is completely knocked out. So heart rate variability is also high, but it's high in a way that's kind of interesting. It looks more like wakefulness in that, because it depends on what we're dreaming. If we're dreaming, we're running, our heart rate goes.
It's variable, but not rhythmic.
Not rhythmic in that way.
It's not taking them because you're not breathing in a sinus. So I would assume that slow wave sleep, where breathing is a little bit deeper, more regular.
Yes, exactly.
And so heart rate variability might have more of a rhythmic pattern to it.
Yeah. And as we get older, that's another thing that goes out the window is that beautiful heart rate variability. It gets smaller and smaller and smaller as we get older. And when our locus coeruleus is active, for example, right now, hopefully you're awake and listening and you're not exercising, so your heart rate doesn't have reason to go spiking up and down. It's probably not very variable because your locus coeruleus says, okay, we're paying attention.
Right. One thing I get from the device, but in general, thinking about the physiology of sleep and what you do during the day and how it affects your sleep. First time I put the ring on ever, I went to a jazz club with my parents who were in town. We ate and drank freely. And then my heart rate, lowest resting heart rate didn't happen in the night until I was about to wake up.
Right.
And the ring told me, that's a sign that you must have eaten something rich and or late or drank a lot.
Yeah.
And I said, wow, that's really intuitive. Let me see if that pattern holds up. And sure enough, whenever that happens, which is very rare, the resting heart rate, the lowest of the night, gets pushed way out.
Yeah, until all that alcohol is metabolized.
Right. Yeah. And obviously heart rate variability is very sensitive to that. So the average for the night is always lower when I either go to sleep later or I've done things to my system like alcohol or anything else that would disrupt sleep.
Yeah. So is this a normal night right there?
This is fairly normal.
Yeah.
I think there was some glasses of wine involved in the evening, but yeah, average is around 50 to 60.
Yeah.
But we'll go down to 20s with a few
That's
glasses
amazing.
or
Yeah.
something like that.
Time in bed, 8.5 hours. Why does it say time in bed? Why doesn't it say time asleep?
Total sleep was 7.
Time in bed.
Well,
That's
because it knows
interesting.
somehow
You can
that
see that
he
big
was
chunk
lying
of-
down in bed.
Right. He's just laying in bed.
Yeah.
Which is interesting. You know, there's been this concept of bed rotting. Have you heard about this?
No.
Yeah.
but-
So it's like you stay in bed as much as possible, not only sleeping, but, you know, working on your computer, working on different things, because maybe we're able to get rest while doing work.
No.
And what do you think about that?
No.
Yeah, that was my knee-jerk reaction too. Yeah.
Yeah, that body resting may reduce your metabolism a little bit, but it's not going to do for your brain and body what you need. It's not going to, growth hormone's not going to be secreted. Melatonin, especially with a bright computer light, it's not going to be secreted. Your brain isn't going to do it. We didn't talk about this, but every sleep state is an entirely different landscape in terms of the chemicals that are active in your brain.
Mm-hmm.
So each one is completely unique from the other. And so, thank you. Yeah, right. That's great. So that's waking is in the first column, where acetylcholine, norepinephrine, which is that locus coeruleus one, serotonin, which is that psychedelic one, all high when we're awake. But then when you're in deep slow wave sleep, the thing that's gone is acetylcholine. Yeah, you see that's like known as acetylcholine. That allows those slow waves to happen, actually. When you're in that N2 transition REM with like those sleep spindles, none of those neurotransmitters are active. It's almost the opposite of wakefulness, you can see. And then during REM sleep, the norepinephrine and serotonin are the things that are not there. But acetylcholine, there's a ton of it. And
that's fascinating.
Yeah, a ton of it. And that helps your brain be as plastic as possible and really do its plasticity clearance kind of thing.
Yeah.
But it's the opposite of slow wave sleep, right? So you can't substitute any of that with just rest. Rest looks like waking. That's if you're awake, that's what it looks like. You're a neurotransmitter.
Have there been studies? I know some scientists out there are talking about different breathing patterns during waking life. I wonder if that replicates at all some of these proportionate neurotransmitter releases.
Right. I think a breathing pattern that allows your parasympathetic system to start dominating would probably calm down the amounts of norepinephrine, maybe serotonin as well. Actually, Jack Feldman here at UCLA is a great one to talk to about that one.
He's had him on before.
I talked to him a long time ago. He's the best. He's so cool. And we were just talking about him before when we were just waiting on you to come in.
Yeah.
We're just talking about having him on again.
Yeah. That would be great. Yeah. So you might be able to get a little closer to the REM state with some different breathing patterns. Hypercapnia or whatever it's called. You're breathing. That doesn't allow your parasympathetic system to dominate. In fact, it's more kind of a sympathetic overdrive. So,
and looking at acetylcholine being high in REM, I assume with less acetylcholine, like in disorders like Alzheimer's, REM is affected because of that, or is that one of the many instigators?
Yeah, one of the many instigators. Alzheimer's, the first thing it affects is the locus coeruleus. So, and the first thing that happens to the locus coeruleus is it becomes hyperactive so that it doesn't calm down during REM sleep. And then when it built all the hyperphosphorylated tau gunks it up and gunks up all of its processes, it starts to have apoptosis. Cells start to die. And so then it becomes hypoactive. So, yeah, it's
many things working against normal sleep.
You've talked about some really interesting interventions for potentially dampening that locus coeruleus. I think you mentioned propranolol.
Oh yeah,
before. And I think orexin.
Right.
Do you mind going into that a little bit? I thought it was really interesting.
Yeah, propranolol is a blocker of one of the 3 major receptors for norepinephrine.
Right.
And so what it blocks is called the beta adrenergic receptor, which is all over our hippocampus. And when the beta norepinephrine activates the beta-adrenergic receptor, so opposite propranolol. And when it's activating it, it causes the cell to not ever let go of any synapses. So that's probably one of the ways that PTSD works. When the locus coeruleus is hyperactive, too much norepinephrine, those beta-adrenergic receptors in your hippocampus are activated, causing your hippocampus to just hang on to all of those memories. So propranolol blocks those. So maybe even if your locus coeruleus is hyperactive, if you block the receptor for it, you might be able to get a REM sleep that's more, your hippocampus at least thinks is norepinephrine free. And then it can do what it's trying to do. So there have been 8 clinical studies with propranolol in not just PTSD, but other kinds of things. And it's worked beautifully in 4 of them and didn't work at all in the other 4. So we're going back to the bench with rats and exposing them to trauma, giving them propranolol in an attempt to cure them of what would be a PTSD, or let them get a PTSD phenotype and then give them propranolol in combination with exposure therapy and see if we can knock them all into, the healthy sleep range again. And we are, one of my graduate students is actively looking at all of the data that she's gathered to see, what happens to sleep with propranolol, what happens to REM sleep, what happens to acetylcholine and norepinephrine and dreaming and multiple arousals and all of that. And can she allow rats to be put back into the normal range? And so far, it's good.
It's surprising that hasn't been done. I mean, propranolol for PTSD.
Yeah, I think
the idea of not consolidating the traumatic memory was back, 90s, early 2000s.
That's right. Yeah. It works amazingly well with people with fear disorders.
So clinically, I like using propranolol in my PTSD patients because it dampens sort of the end organ effects of having PTSD exacerbation. But I think of it in terms of racing heart, rapid respiratory rate, and then
during
sweating the
wakefulness.
hands. Exactly.
Yeah.
I never thought about it in the context of sleep.
Yeah. So strangely enough, even though it doesn't calm your locus coeruleus necessarily. Maybe this is the problem. It just blocks the receptors for the locus coeruleus, and it keeps even our rats, but also people, awake longer. And so why would that be? If you're blocking the receptor for it, maybe you're blocking also some feedback loop that you could be doing, especially during wakefulness when you're trying to learn about and resolve this trauma and have it calm you down. If you're blocking those receptors when you're awake and trying to do exposure therapy, I mean, okay, there's different levels. So norepinephrine is like a lot of other things. A little bit of it is a great thing. Too much of it is a bad thing. And none of it's not good either, except during REM sleep. So too much of it is panic. So if people are going from panic to the good zone with propranolol, then they can learn better. They don't have all that panic flooding their brain. But then you want to go from that zone into REM sleep where you have none of it present. You don't want that none of it present when you're awake and trying to do extinction learning or exposure therapy, but you probably do want it during sleep. But anyway, for some reason, it prevents a lot of REM sleep or sleep at all. And so maybe what you need to do is combine, because actually there's a relationship between norepinephrine and melatonin as well. Maybe you need to combine it with melatonin therapy So
it sounds like in a perfect world, we could have a 90-minute timed release of propranolol.
Exactly.
In an extended release form.
I like that. Or some wearable that allows you to know when you're in REM sleep, and then it suddenly gives you a boost of propranolol.
I really want to circle back to this, being able to employ sort of these sleep strategies or something similar after some sort of traumatic event to be able to alter the course for someone's diagnosis of PTSD. And I want to, employ maybe some autonomy. Maybe you can provide people that autonomy to, if something does happen, what should they be doing from a sleep perspective, if anything?
Yeah. No, I think that's a really great question. if you can, just after a trauma, try to get to the point where you could cognitively resolve what happened and how you can avoid it in the future, because that will already allow you to step down your sympathetic nervous system. And then when you do go to sleep, get a normal night's sleep. If it takes extra hours to do that and you don't get much sleep at all the first night, that's okay. That's okay. So sleep on it is a good thing to do under normal circumstances, but going to sleep when you're still hyped and stressed is probably not the thing to do. So find a way to come to your, Zen zone before you go to sleep. And then don't be disturbed. Don't worry about the nightmares, because that's normal to resolving it, especially if they're bizarre. Welcome the bizarreness of those nightmares, because that shows you that your locus coeruleus is shut off like it needs to be, and you're incorporating all these bizarre things with those subcoeruleus activations. So, I guess those are the main things, is find a way to find your Zen zone. And I think that's why post-trauma psychological counseling, like the afternoon or the day of trauma, can be great or it can be worse, because kind of psychological counseling, which just has you relive the trauma, could keep your sympathetic nervous system activated longer than it would otherwise be. If instead that psychological counseling or talking to your friend allows you to resolve it, allows you to come to a place where you can resolve it and then calm down. And that's probably why that works in some cases and doesn't work in other cases.
Yeah, that's a fair point.
I have to ask about the amygdala. That's been my area of interest.
Yeah.
It's not quite blue, but it's almond shaped. There's two of them. I'm just curious. It sounded like, from some of the things you've said in the past and some of the things it sounds like you're learning about, the subcortical regions deeper in the brain that you're not measuring with EEG, having a different pattern and a different behavior than the cortical ones. What is the amygdala doing during these different states?
Yeah, so the amygdala is part of your emotional system. Fight or flight is a big part of the amygdala. And so interestingly, it's normally actually really active during REM sleep, normally. And that activity in the absence of locus coeruleus norepinephrine allows the amygdala to do the same kinds of things that the hippocampus does, which is amplifying some memories, like maybe extinction memories, and pruning away others that might be more kind of related to things that you're learning aren't as adaptive. So the emotional system activation in the absence of norepinephrine is good. Now, interesting, during REM sleep, we didn't talk about this. The prefrontal cortex is pretty much off. And that is good, because if you're activating your emotional system while your logical system is off, it helps break apart the memory, the logical semantic memory, this happened to me, from the emotions that are activated during it. So so the two, one is silent and the other is active. It's kind of like knocking at a door and nobody comes to the door. So eventually you go away. And so it helps weaken that connection. Similarly, if your emotional system is really activated, it's kind of like pressing the doorbell, or it's actually like, ding dong ditch. You press the doorbell, your brain says, what? And then there's nobody there. Eventually you're going to start ignoring the doorbell. It's helps weaken that connection. Yeah.
About right-left brain, is there a difference in hemisphere?
Yeah, there is definitely a difference in the hemispheres. I don't know as much about right-left amygdala. Maybe you can tell me about that.
It's a really complicated space and differs by sex as well. But I'm thinking more about right-left brain during sleep. Is there a different pattern of activation? You described prefrontal versus hippocampal and other regions as separating logic from emotion. There's obviously a difference in logic and emotion when you think about right and left brain. Is there a difference in activity?
That's a really good question. I can't think of any studies off the top of my head that have really delved into right-left brain differences while we're asleep. There are animals that unihemispherically sleep, but that's not us. So, but it would make sense that there would be some differential activation. Yeah.
You mentioned the sex differences thing, and what a component I'd like to highlight is the gender differences in sleep, but then also specifically focusing on women's sleep.
Yeah.
Because I think that's very unique and should probably be discussed about a little bit more. Right?
Sure,
Especially
absolutely.
considering the hormonal fluctuations that women undergo throughout a lifetime.
Yeah, we haven't done a good job studying that.
Yeah.
Women and females in general have been sort of ignored.
Here we go.
Yeah, and all of the studies of the locus coeruleus activity and those neurochemical patterns that I showed you a minute ago were all done in males. So really, my lab is the very first one, and this is one of my students, Yesenia Cabrera, who's recording from the locus coeruleus in a female. The very first time in all of history.
Really?
For
First
this.
time in history?
In history, anyone's ever recorded from the locus coeruleus of a female. And yeah, I know it's wild.
Crazy.
I know. And so we did find differences. So here's the male pattern of locus coeruleus activity during waking, non-REM, which is the same as slow wave sleep, and during REM, it's like almost down to 0. And then females at high hormonal stages when estrogen and progesterone levels are very high. So we also look a lot like males, right? But at the low hormonal phases, which in human females is about half the state, half the time, half 2 of the 4 weeks. And in rats, it's 3 of the 4 days. They have a 4-day cycle. The locus coeruleus doesn't calm down like that during REM sleep, which is really interesting, fascinating, and could have a lot of parallels to why women get Alzheimer's more often, why they have PTSD, anxiety disorders.
And more susceptible to PTSD.
And more susceptible to all of these things.
So REM is really the differentiator here for women who are in a low
hormonal state.
In rest.
Yeah. And this is not women. We can't record from the locus coeruleus of women yet.
Female.
Female. This is female rats here.
Got it.
Yeah.
Interesting. Can we hit a trending topic? Mouth taping at sleep? What do you think?
I don't even know what this trend is. Tell me about it.
What? Oh, you don't know about mouth taping? Are you kidding?
No.
So people are taping their mouths when they go to sleep.
Shut?
What's that?
Taping them shut?
Totally shut. Yeah. And because, there's reportedly there's improvements to sleep, sleep quality.
Very interesting. I'm going to have to talk to my dissertation advisor, Ron Harper, about that because he has studied obstructive sleep apnea and all of that. Well, I think it would be dangerous if your nose is clogged.
Right. If you're ill or you have
just thinking about taking the tape off. Right. That's all I've been thinking about since you brought it up.
Right. Yeah.
I wouldn't do it.
You wouldn't do it?
I wouldn't do it. But again, like if you're healthy and it feels like you're sleeping better, you do it. Go for it. I don't think it's going to kill you under normal circumstances.
Right. Maybe we'll also talk to Jack Feldman about it too.
Yeah. I mean, breathing through your nose is what we normally do. But people with obstructive sleep apnea breathe through whatever orifices they can. And so maybe I think mouth taping would decrease your snoring, make you breathe through your nose better. But if your nose is not if
clear.
you have a deviated septum or what, a clogged nose, I think that would be a dangerous bad thing.
Yeah, probably.
What is the next frontier? Maybe for your lab or for science in general.
Oh my gosh. It's such an exciting time to be doing research right now. The tools we have in neuroscience to look into these things and we've awakened to the fact that, we need to look at females too. Oh boy, they might be different. All of these things are coming together to make the pace of discovery just so much faster. So one thing that I'm really excited about, it'd be hard to describe, but I'm going to do my best here, is, the function of sleep for consolidating our memories, for putting them away into the cortex, and then cleaning our short-term memory structure in the hippocampus. That relies on a microcircuit within the hippocampus and between the hippocampus and the other areas of the brain. How do we know when our memories are consolidated and we can erase them from our hippocampus? We don't want to erase them too early, right? Because if they're not yet consolidated, we'll just forget. So we need to have some sort of feedback signal from the brain that tells our hippocampus, okay, we've got this now. From the cortex, I've got it now. You can let go. So that's what I'm studying right now. And in the past, I couldn't have studied this before because we didn't have all the tools to be able to manipulate different neuronal types in this microcircuit. We only had these gross tools like stimulate it with electricity, and then you're stimulating all the neurons in the microcircuit, and you can't, it's just too much of a hammer, or inhibit the whole thing with anesthesia. And that doesn't get you at the questions either. So it's really exciting because we have all of these molecular tools that allow us to target certain types of cells and make them release neurotransmitter when they wouldn't, or whatever, and just to see what's the function of this, what's the function of that, what is the circuit that allows us to know, when we're done consolidating memory and we can erase it, and what is the importance of norepinephrine? What does norepinephrine do in this circuit? What does serotonin do in this circuit? How can we then replicate, once we know these things, how can we then use, instead of this big hammer pill like opiate, how can we manipulate just subparts of the circuit so that we can optimize our brains?
Or like you said, duration of timing of medication. Okay, so what about summarizing? Like if you had to, give your best advice to someone out there that, is suffering from insomnia, difficulty going to sleep, maybe having more frequent awakenings than they would like, or waking up tired when in fact they've slept 8 hours. What are some general recommendations that you think everybody or most people might be able to take to the bank?
Yeah. Oh boy. So we've talked about so much.
I know.
One thing, you can't sleep too much. Maybe it's your immune system has been activated by something that you don't even know is happening. Or you have sleep apnea and you don't know you had. And so you're sleeping 9 hours, but you're actually only getting, 4 broken up hours of sleep in that 9 hours. You've awakened 500 times and you didn't even know it. So you can't sleep too much. If you, on a given morning, wake up groggy, if you possibly can, go back to sleep and just wake up spontaneously when you can. I don't use an alarm clock most of the time. Of course, I do have a dog that wakes me up at this particular time of night. And when I had young kids, they would wake me up too. But most of the time I sleep without an alarm clock. And then, so that's one thing. You can't sleep too much. Your brain is super active, doing all kinds of things for you that it can't do when you're awake. So you are not being lazy when you sleep. And I say, in general, if you possibly can, listen to your body. If it says, I really need a nap right now, you've been studying calculus or whatever it is, and you're like, boom, in your head, let yourself sleep until you wake up with the drool on your book. That's fine, because what you're doing during that time is that N2 stage sleep. The sleep spindles are going crazy trying to say, okay, how does this fit with everything I know? Do I need to make a whole new schema for this? And that takes energy and time and sleep.
And it sounds like probably individually based relaxation exercises to make sure that locus coeruleus isn't.
I think one of the things that keeps normal people up at night and worrying about their sleep is the sometimes these wearables, for example, make us think, oh my gosh, I didn't get any REM. Take it with a grain of salt, relax, and just, I guess that's the bottom line, relax. You're probably going to be okay unless you have a sleep disorder like apnea, in which case you should definitely get it treated. But the best way to battle insomnia most of the time is to relax about your sleep, because worrying about your sleep activates that locus coeruleus, and that you're not going to get to sleep if you're worried about it. So a lot of the things that people do to help themselves sleep better, magic pillow, whatever it is, placebo. But the placebo effect, the power of the placebo effect is it calms you down. It's like, I'm going to get a good night's sleep because I've got a magic pillow now. And so then, and you do get a great night's sleep. So play around with it, see what it is that helps you sleep best, and do that. Sex is actually pretty good for sleep.
Oh, we're definitely not going to edit it now. Definitely not.
Hey, we need to know the truth.
I talk about parasympathetic system, then the sympathetic system, and when that's a big reset. that sympathetic system at the end with orgasm allows you to.
So, right. So sympathetic during sex, after there's a big parasympathetic, and that's a good time to just ease into bed.
So during usually, exactly.
Yes. Yeah.
Okay.
Yeah.
Let's just say it for that.
No
way.
more details.
Well,
Timing?
No details.
Timing? Does timing matter?
Timing is everything.
All right.
So if your wife is awake after you, it might be that she faked it.
Oh my gosh. That's
might have to
amazing.
work a little harder.
All right. Okay. So we're going to do two things. We usually just do like a 3-2-1 closer that involves 3 facts about sleep, 2 fictions about sleep, 1 thing anyone can do to improve their sleep.
Mm-hmm.
But I came across a different numbered rule called the 10-3-2-1-0 rule by Jesse Andrade, who's a sports medicine doc, who basically states, cut out caffeine 10 hours before bed, don't eat or drink alcohol 3 hours before bed, stop working 2 hours before bed, get away from your screens 1 hour before bed, and avoid hitting the snooze button in the morning. Do you have any issues with any of that?
Everything is good except the snooze button thing.
Avoid hitting the snooze button.
So I think the reason why you want to avoid hitting the snooze button, because basically if you want to hit the snooze button, you haven't gotten enough sleep.
There you go.
So to avoid hitting the snooze button, just set your alarm for an hour later or 2 hours later or whatever, and then let yourself wake up spontaneously.
Yeah.
And then in the 3-2-1 closer, 3 facts about sleep that you find compelling, 2 fictions. What do people get wrong here? And then 1 thing anyone can do today to improve sleep.
So 3 facts. 3 facts?
3
facts about sleep. Your brain is really active and doing great work. So do not disturb.
Mm-hmm.
It is stuff that you can't do when you're awake. And let's see what else. I guess I can go into the stuff, but that would be much more than 1. That would be about 27 things your brain is doing.
Yeah, like you haven't given us enough facts at this point, right? But,
right.
Yeah.
So that one is that, many of the things that the brain is actually doing, cleaning your brain, for example. And then 2 things that fictions. Oh, well, 1 thing that I would like, I think it's already dispelled, but I want to just dispel it even further, is that this whole poly sleep schedule thing where you can sleep for half an hour and be awake for an hour and, do this all day long. No, you really do need this contiguous sort of cycle of sleep. And 1 full cycle is a beautiful thing, and 5 full cycles is even better. So don't just think that you can go to sleep at any time and wake up any time and you'll be fine. There are things that happen. Timing is everything.
Mm-hmm, mm-hmm.
And then insomnia. That thing about alcohol, definitely alcohol disturbs your sleep.
Mm-hmm.
And if it doesn't, it disturbs your sleep on the first when you first fall asleep. And then when you metabolize the alcohol, it disturbs your sleep the other way. So it's neither one is good for sleep.
Mm-hmm.
So I guess, is that 2 things?
Yeah. And then 1 thing anyone can do right now to improve their sleep.
Listen to your body.
Love it.
Amazing. Okay.
Thank you.
Thank you so much for joining us.
Thank you for having me. It really was.
I always say this, and I honestly always mean it, but I especially mean it today. Thank you so much for joining and sharing with us all your knowledge, and thank you for all the work that you've done over the last 20, 25 years in this field. It's truly an honor to sit across from you.
I appreciate it.
I really appreciate it, and I'm sure our audience is going to really appreciate it too. So thank you very much.
Thank you, the audience, and thank you guys both for doing all the good work you do with this podcast and with your day job.
Yeah. Should we direct people to a certain website or anything where they can do your work?
Yeah, I haven't written a book and I don't have a great website.
It's just a matter of time with the book thing, right?
Yeah.
Right?
There are a few papers. Like there is 1 good paper that we published just last year about the effect of circadian rhythm disruption of athletes traveling across time zones. That was published in the Journal of Sleep Research or something like that. I don't even know where it's published. But anyway, you look up that. Craig Heller that I talked about is the senior author on that paper. I'm one of the many authors. And so that's a good one because it's the diagrams talks about the different things that different stages of sleep and times of sleep do for you. I think that's a good one. There's the National Sleep Foundation website that has a lot of good information. That's really plugged in with the whole sleep research field. So the information on that website is very, very accurate, and it gives tips and tricks on how to sleep better and when to see your doctor and those kinds of things.
Yeah, excellent. All right. Thank you, everybody. This is the Better Brain podcast with Dr. Poe. Thank you very much. Thank you so much for joining us. And remember, get better sleep, listen to your body. Most importantly of all, be better.